Morning, everybody. Welcome to Talking Point Tuesday. This month's theme is health economics, and I'm just going to go through some introductory slides, and then we'll move on to the main theme. So my name's Laura Musgrave. Oh, it's a bit loud. I'm the Industry Partnership Lead at the Innovation Observatory, and I also work for the Research Support Service as part of the NIHR as well. So our calendar of events, next month, so April is digital health tech, and then in May we're moving on to sustainability and health, PPIE in grant applications, so what you need to include in your funding and your grant in terms of PPIE and inclusivity, and horizon scanning globally, so internationalization, global reach. So that's the next calendar. So typical itinerary for any Talking Point Tuesday. So it's an hour physical networking, and then we move into speakers, and we have normally 3 keynotes, maybe 4, depending on the subject. And then we have expert panel, fireside chat, followed by the opportunity to have a one-to-one with experts and virtual residents. I think we've got a slot available still today, 2 slots. So if anyone wanted a slot, if they either put it in the chat or catch me at the end. So the idea of the expert and virtual residents is to have a one-to-one in confidence. So obviously there's going to be questions in terms of commercialization that you're not going to want to say in the group or in a group audience. So it's the opportunity to have a 10-minute slot with our in-house resident experts and keynote experts as well, just specifically tailored towards your business. So in terms of industry resources, so for the Innovation Observatory, just highlighting and signposting you to the key resources. So on the website, we have a resource page, and that's split into reports, dashboards, and technology briefings. So the technology briefings are briefings that we do for NICE. So some of the public information is on the website, and I found it really useful lately. So I've been working with some SMEs that are going for I4I funding or NIHR funding, just to be able to reference some of the intelligence insights data that's on the resource page. So someone I was working with was working in UTIs, and there's some horizon scanning reports on there. AI and neurotech for another person. So it's definitely worth going onto the resource page and having a look to see if there's anything pertinent to your subsector organisation. So that's the resources page. So I mentioned that I also work for the Research Support Service. So there's a hub for the RSS delivered by Newcastle and Partners. So for more information, that's a QR code to go onto it. But the RSS can support in terms of any of your applications, grant applications. So if you're an SME and you're going for funding from NIHR, potentially I4I, Connect, we can help you with your research for that and signpost you in terms of PPIE as well. So that's kind of a whistle tour to the Innovation Observatory and what we do with industry. And I'm going to hand over to my colleague, Gurdeep.
Morning, everyone. Good to see a few people in the audience. Welcome to those online. So my name is Gurdeep Sagu. I'm a senior lecturer in health economics at Newcastle University, where I co-lead the health economics group. I'm also the health economics lead for the HRC, and Johanna, my colleague, will introduce the HRC in the second of the 3 presentations. And then Chico in the 3rd presentation will give an example project that we've undertaken through the HRC that involved health economics. So my task is to introduce health economics, and I've only got 20 minutes. So it's going to be a bit of a whistle-stop tour, and I'm not going to be able to do everything. So I've chosen to focus on 3 particular things. So very briefly, introducing the concept of health economics, what it is, thinking about priority setting, and I'll mention scarcity and choice a few times. I'm going to talk a little bit about cost, and in particular, think about the concept of cost that health economists use. So we're interested in opportunity cost, really. And then I'm going to spend probably about half of my time on economic evaluation, because when we talk to SMEs, primarily what they're interested in is economic evaluation. And in terms of economic evaluation, so Dawn mentioned forwards, the future Talking Tuesdays, but the previous one, so the one in February, was about early economic evaluation. And so that's well worth looking at if you haven't seen that one already. So what is health economics? Very, very simply, health economics is the application of the discipline of economics applied to the healthcare sector or the healthcare field. Economics is primarily interested in the production, distribution, and consumption of goods and services. And so if we take that and we apply that to healthcare, that's what we're thinking about in terms of health economics. So what are we producing, how we produce it, and how we then distribute what we produce so that we as a society can start to consume that. So when we think about health economics, we're thinking about health and also healthcare. And so those two, health and healthcare, are not insubstantial things in their own right, but we're trying to use the tools, the frameworks, the analytical thinking, and the theory of economics and apply that to health. So that very simply is health economics. So health economics, when we think about economics, quite often we're thinking about markets and how markets work, and so how buyers and consumers, sellers, all interact, and how people behave. So that generally works pretty well in non-health fields, not perfectly, but generally pretty well. But when we start to apply that thinking to health and healthcare, it gets a lot more complicated for a variety of reasons. And some of those reasons I've put on this slide. So markets in healthcare are not necessarily competitive. They're difficult to set up. They incur a lot of cost, a lot of resource to try and set up. So it's not easy to enter or exit a market. So if I wanted to sell cars, I could pretty much just go away and start doing that. So I could buy a car if I've got the capital to do so, and then I can try and sell it slightly more expensive, make some money, and then I can just keep doing that until I'm able to set up a car business. But in terms of if I wanted to change this building into a hospital, it's a lot more difficult. Or if I wanted to set up a GP surgery, it's a lot more difficult. So there are lots of reasons why I couldn't do that. So that's why, markets don't necessarily work quite as well in healthcare. Also, health is a really difficult thing to it's not really a marketable product. So I can't go to the supermarket and like I can pick up a lasagna or a loaf of bread. I've got a good idea of what those things are going to do for me and what I'm going to get for them and how much they cost. But with health, it's a lot more difficult to do that. And I know that we have a lot of health and healthcare products marketed at us, but it's not quite the same. So I can't go to my hospital and say, I want this particular surgery for this particular reason. It doesn't quite work like that. So it's a lot more difficult. There's also this idea of information asymmetry. So in a perfect market, there is no information asymmetry. So the buyer and the seller both have a similar amount of knowledge, so they can interact well. In healthcare, that doesn't really exist. So what we need is actors to act on our behalf. So the clinicians, the doctors, the GPs, physios, whoever it is, pharmacists, we need them to act on our behalf because we don't have the information that we need to be able to make this a better transaction. And so patients normally lack the necessary information about their condition and about the potential treatments that may be available. So we need someone to act on our behalf. So that's another reason why, health economics is slightly different and unique and a little bit more challenging, but it makes it fun. Well, from our perspective anyway. So why do we need health economics and why do we need health economists? So we're going to be moving over onto this concept of having to make decisions, having to prioritize, having to make choice. So we need to make decisions, and health economics and health economists can help inform decision making. So that is the ideal goal of economic evaluation and health economics, is to help these decisions to happen. So in terms of healthcare, we need to try and think about how we allocate the resources that we have for health and healthcare, and also what healthcare interventions that we should be providing, because we can't do everything. And I'll come on to the we can't do everything in a minute. But the idea behind health economics is it's based on welfare economics, and the goal, I guess, is to try and maximize our health. That's what our health budget should be paying for, is societal health. And so that's what we're interested in. We're trying to spend this money to try and maximize the health of our society. And so if we're wanting to make fair choices, we need some methodology to do that. And so health economics and economic evaluation is about trying to create this systematic comparison of costs and consequences or outcomes of competing interventions, so that we can try and inform a decision on both the costs and consequences. And so one of the criticisms that health economists quite often get is we're quite interested in saving money. No, we're not. Health economics is not about, just the money side, and it's not interested in just trying to save money. What we're trying to do is we're trying to maximize the health that we can get for the amount of spend that we have available for that. So the idea of scarcity, this is quite an important economic concept. So the idea here is that we have limited resources, whatever those resources may be. So it could be number of beds, it could be money, it could be time. There are lots of different resources, but by and large, they're all limited in some way. And so when we think about healthcare, we can see from the figure that the demand for healthcare has increased over time. So the bubble is getting bigger. And this is because, we've got an aging population, but we've also got a bigger population, very simply. So the demand for healthcare is increasing. But counteracting that is the fact that lots of good scientists and researchers are doing lots of excellent work, lots of SMEs doing lots of good work to try and develop effective interventions. And so that is also increasing. So we're getting a greater number of effective interventions. So compared to 60 years ago, healthcare looks completely different. It's so much better than it was back in the day. So those two trends are going in the right direction. And whilst healthcare budgets have increased, it hasn't quite increased enough to keep up with the demands and the potential interventions that are available. And even if it were able to, there would still be a different constraint. So there would still be scarcity somewhere else. So the idea of having to make a choice would not go away. We would just be having to make a different type of choice. But at the moment, one of the choices that we have to make is that we've got a limited healthcare budget that is available to spend on all these potential wants and needs and interventions. And so we're having to make these choices to try and think about what we're prioritizing and what gives us better, better health for the spend that we have. What is more value for money? And so when economists think of costs, or a health economist thinks of costs, what we're trying to do is we're trying to really think about opportunity cost here. An opportunity cost can be thought of as the foregone benefit. So if we were able to spend that money again on the next best alternative, what would that next best alternative be? And so that is our foregone benefit. So you guys are all here, but you could have been somewhere else this morning, but you've chosen to be here. So if you think about your time, what could you be spending that time on if you weren't here? And what is the best possible use of that time? And that gets you into the thinking of that is the foregone benefit. So that is the idea there. So we're having to make these choices. Once we've made that choice and we're incurring that cost, whether it's time, whether it's physical money, that is spent. And so our opportunity cost is, okay, what is the next best alternative that we could have used if we hadn't done that? And so given that we can't fund everything, because there is scarcity somewhere, there is a limited resource somewhere, we're having to make these choices. And so what we want to do, I guess, as a society is trying to make those choices as transparent as possible, but also try and make them efficient and equitable. And so if we can think about this concept of opportunity cost, that is one of the ways in which we can do it. So it's not quite a case of one in and one out, but we do have to try and use our resources as wisely as possible. and as efficiently as possible so that we can maximize what we would like to maximize as a society. So in this case, health and healthcare. Okay, so that is health economics in a really, really, really tiny nutshell. Now what I want to move on to is economic evaluation, because economic evaluation is one of the analytical frameworks that we use in health economics. There are others. So health economics is quite broad church, but when we apply it to SMEs in the context and in terms of developing technologies or evaluating technologies, most of the time what we're really interested in is economic evaluation. And so economic evaluation can be defined as the comparative analysis of alternative courses of action. So at least two interventions in terms of both the costs and the consequences. So in order to be a full economic evaluation, it has to have both of those components, both the costs and the outcomes or consequences. A partial economic evaluation can focus just on the costs. But for the purposes of the next sort of 10 minutes or so, I'm just going to focus on full economic evaluations. So partial economic evaluations do have their role and can be helpful, but I'm just going to focus on full economic evaluations. And so economic evaluations can take many forms, but some of the tasks involved remain the same. So the idea is that we need to identify, measure, and try and value both the costs and the consequences of the interventions that we're interested in comparing. So very, very simply, the steps in an economic evaluation revolve around the perspective, the costs, the outcomes, and then the actual type of economic evaluation that you're going to try and undertake. So I'm going to go through each of these in turn. But in terms of the types of economic evaluation, so I mentioned full forms of economic evaluation. So they are cost effectiveness analysis, cost utility analysis, and cost benefit analysis. And generally, when we talk about cost effectiveness, we can talk about all of these forms. But when we start talking about specific analyses and specific frameworks that we're going to use, then that's when we move between cost effectiveness, cost utility, and cost benefit, because they're all similar but different. And so I'll go through those differences. So why is perspective important? Basically, if you have a decision problem, your perspective allows you to try and draw where that box sits around it. So different perspectives. So in the NHS, UK NHS, and for NICE, the primary perspective for that is the healthcare provider, so the NHS. So what we are interested in is the costs and the consequences as incurred or delivered by the NHS for the NHS. But we can widen that perspective and we can make that perspective more narrow. So we can also think about patient perspective, employer perspective, and the broadest form of perspectives, which is society. So NHS guidance, sorry, not NHS guidance, NICE guidance suggests that our primary focus should be healthcare, should be the NHS perspective, but they do also give us the option of doing a societal perspective as well. And that is, I think, becoming slightly more common as we go forward, because there is a greater understanding of the non-health impacts of lots of different technologies now, and how we try and incorporate that into decision making as well. And so it's important to say at this stage that costs and outcomes that are relevant from one perspective may not be relevant from another perspective. And so what you want to try and do is you want to try and choose the perspective that is most appropriate for your technology and for your decision problem. Given that NICE would prefer a healthcare provider perspective. So it's trying to trade that off. Okay, so costs. So when we're thinking about costs, what health economists and economists are really thinking about is opportunity cost, but also what we're thinking about is resources. So what resources are being consumed? What resources do we need to deliver what it is we're interested in delivering in terms of the intervention? So what we need to do in an economic evaluation is to try and identify those resources that are needed, then to measure those resources, and then to try and value those resources using monetary values. So identifying resources could be, if I need to do a surgery, where do I do it? How long, where do I do it? Who do I need to be doing it? What consumables do I need? Those sorts of things. So these are the resources that I need to be delivering the surgery. Measuring could be, so how many types of person do I need? How long do I need the room for? How long do I need the various different people for? In terms of the consumables, do I need 6 needles? Do I need 5 test tubes? Do I need, what are the pieces of kit that I actually need, and how many of them do I need? All these sorts of things, beds, sheets, etc., measuring those resources, and then assigning a monetary value to those resources. So if I need 6 surgeons for whatever reason, how long are they there for, and how much do they cost? What is their salary, for example? We're trying to think of those things. If we need 6 bed sheets, or 5 needles, or 6 test tubes, how much of each of those, what the cost is for those, what the prices are, if you've got a price, and then try and use that to work out how much it is your intervention is costing. And then we try and do something similar with regards to outcomes. So what we are interested in is trying to identify what it is we're trying to get from our intervention. And this could be both health-related and non-health related benefits. We want to try and measure those benefits in the most appropriate way. So it could be a clinical measure like blood pressure. Are we reducing blood pressure by doing something? HR-QoL is health-related quality of life. So that is a way of trying to measure an individual's quality of life, or their perception of quality of life. And the idea there is that we try and use their perception of quality of life with the duration of time of life that they have, to try and come up with a quality adjusted life year. So that is about assigning the value to the effect. So some things are easier to value than others. So again, similar thinking about the costs, but applying it to the outcomes or consequences. And then before we bring that together, we need to decide how we're going to bring it together. So we want to try and think about what type of economic evaluation it is we're wanting to do, given that we've got 3 full forms of economic evaluation. So cost effectiveness analysis, cost utility analysis, and cost benefit analysis. And which particular technique you use, or which particular analysis method you're using, depends on the question that you're actually trying to answer. And as I said earlier, they're all similar, but they're also different, and they differ with respect to the outcome measure that they are trying to capture. So we try and measure costs and identify, measure value costs in the same way, but the perspective may change. But in terms of the outcomes, that they can be very different between the 3. So measuring outcomes, if we're interested in doing a cost effectiveness analysis, so the effectiveness part of that tends to take natural form. So something that is easily capturable. So it could be an individual's level of pain. So you can give them a scale and say, on a scale of 1 to 10, how much pain are you in? So it's relatively easy to capture. In terms of events and episodes, so what you might be interested in is, once your intervention's happened, does this individual have a heart attack within the next 30 days? Or, do they have another event that happens within a certain period of time? And it's relatively easy to capture. It's a natural event, or an adverse event. So if you give an individual a drug, do they get a rash? Do they get diarrhea? All these sorts of things can be relatively easily captured. So those are all natural events, and they can all form the outcome or consequence of a cost effectiveness analysis. In terms of cost utility analysis, this is a particular form of cost effectiveness analysis, whereby what we're interested in is trying to get a QALY. So you may be familiar with NICE's QALY framework, and their ISA being a certain threshold per QALY. So here we're trying to capture and estimate those QALYs, and we can do that using a couple of different means. So we can either try and take a generic approach, or we can take a condition-specific approach. And the most popular one probably is the EQ5D, which is recommended by NICE. That's their preferred generic measure of health-related quality of life. And through capturing that, we can try and estimate a QALY. And so we can get our cost per QALY in a cost utility analysis. And then the difference for the cost benefit analysis is that what we're trying to do is we're trying to, so we have our costs and monetary outcomes, so pounds in the UK. And what we're trying to do with the cost benefit analysis is we're trying to convert the outcomes or consequences into monetary value as well, so pounds in the UK. And we can do that in a couple of different ways. So either through revealed preference methods or stated preference methods. So this is when I say, health economics is quite a broad church. So you could spend hours and hours just talking about these things. You can spend hours and hours talking about, health-related quality of life. I will just briefly touch on the fact that these three different analysis methods are different with respect to their outcomes for these reasons. So we've looked at our costs. This is super fast, I know. We've looked at our costs. We've looked at our outcomes. We need to try and bring them together in some way. So this is where we have our incremental cost effectiveness ratio. And apologies, it's a figure. It's a mathematical equation, technically, albeit a simple one. So here, what we're interested in is trying to work out what the extra cost of providing an extra outcome is. So we do that by comparing the relative benefits and costs to each other, the two interventions. And so we have the cost of intervention intervention 2, and we take the cost of intervention 1 away from that. So we've got a difference in costs, and we do the same for the effect, so that we've got this bit, the difference in cost over the difference in effect. And so that gives us, if we're interested in the cost utility analysis and using QALYs, we've got an ISA for a cost per QALY, which is where the 20 to 30,000 pound willingness to pay for a QALY, that nice often use, is used. And so once we've got that ratio, deterministically, what we can do is we can plot it on a cost effectiveness plane. And here we've got cost on the y-axis and we've got effect on the x-axis. So better, more expensive, cheaper, worse. And so in an ideal world, if we have a new technology, we would like it to sit here somewhere in the southeast quadrant, where it's not only it's better, but it's also cheaper. So that's a win-win. Where we don't want it to see is we don't want it to sit here because that's more expensive and worse. So that's a lose-lose. But quite often we see something in this quadrant, the northeast quadrant, where we're increasing cost, but we're also getting more health for that increasing cost. And so we've got to make some sort of decision as to whether we think that is value for money. And this is where we return back to that opportunity cost idea again. So we use nicest threshold as that opportunity cost. So if we think that 20 to 30,000 pounds per QALY is worthwhile paying for, is value for money, then we can impose that threshold on this plane, and we can then see where our deterministic point falls very simply. So if it falls to the south of that threshold, we think of it as value for money because it's lower than that threshold. And if it sits to the north of that threshold, it's not value for money. And that's very simplistically, not to say that we throw one out and we take one in. There may be other reasons why we may choose to do something that falls above that line. And there may be other reasons why we choose to reject something that is slightly lower than the threshold. So it's not quite, if you're below the threshold, we'll do it, because there may be other reasons why you choose not to. And just to finish, this is just a slide of the three full forms of economic evaluation in terms of the benefits and the units of measure, just to show those differences again. So the costs are all the same, so they're all pounds and pence in the UK, but the benefits are slightly different, and in the cost benefit analysis it's slightly wider, so you can incorporate non-health aspects. I don't want to say relatively easily, but more easily than the others. And it's the units of measure that, or the outcomes or the consequences that are primarily different between the three forms. So natural outcomes, utility, so QALYs and DALYs, however you divide those, or money in terms of the cost benefit analysis. And hopefully that's my timer for 20 minutes.
We'll take questions at the end. So if you've got any questions, just hold on to them until after Jana's presentation. Thank you.
Hi, hello. Is this working? Okay, cool. Hello, I'm Jana Sutlan, as you can see on the screen. I'm part of the kind of medtech evaluators. So my disclaimer here is I'm not a health economist, I'm a statistician, and a methodologist, but as a technology evaluator or as a diagnostic evaluator, I have an overview of the whole, let's say, process of evidence development, and then kind of I can give you a bit of non-expert opinion of what you need to kind of consider as maybe SME, but generally developer going through this process of generating evidence. So let me move on. The NHR is co-funding this infrastructure, so the Healthtech Research Centres, or even the Healthtech Research Center networks. So this is a network of 14 HRCs that are listed there and that you can see. So the 14 HRCs, they have a different, each one of us has a specific target focus or more target focuses. So either there is a difference in clinical team that we cover, or there are differences in types of evaluations, or even in the some HRCs are even focused towards the development of their own devices. So definitely the network can help you navigate the kind of addressing the right HRC that you need for your research. But just to let you know that our aim is different, and also not all HRCs have the health economists in the house. And then you might, if health economics is something, it's a work package that you need to deliver, then you might think about approaching the ones with health economic availabilities. In Newcastle, we work as a partnership between Newcastle University and the NHS Trust. We are hosted by them, and briefly half of our colleagues are also employed by the university. So we bridge pretty well between these two institutions. So addressing or having a good connection both with academics, so the clinical academic side, and reaching into the hospital, so having clinical expertise at hand. Our aim, of course, is to ensure better diagnostics are available quickly, or quicker than that was possible in the past for the patient. So patient benefit is the core of everything that we do. So as mentioned, we have our clinical focus as well. So this clinical focus is in line with both research activity and clinical activity of Newcastle as a whole. We have the infection team, the aging and multiple long-term condition team, and then the precision medicine and rare disease. So these are three broad teams that we focus on, and the technology would be in remit if it falls under one of these broad teams. So under precision medicine, there is a lot of cancer research that goes in there. Under rare diseases, again, there are rare dementias, there are other rare diseases that might fall under there. So I think we are quite broad in terms of let's say, you being able to fit your clinical area under these three teams. This is our core team. So we have directors, seniors, health economic lead has just given a presentation. We have our support team and methodologists with a different skill set to apply to the research. So generally, there are two ways how we work with the companies. So our infrastructure is funded by the NHR. However, that does not cover all the research costs that incur part of additional research endeavors. So this means that we need to look for grant funding, and we usually co-develop grant proposals as co-applicants, collaborators, sometimes even as subcontractors together with the company. We even support them assembling the team. So potentially, if you need additional partners to fulfill some of your work packages as planned, then we can look for partners to include or to include in the network. The second possible way is to have a commercial project. So sometimes bigger companies or companies that have received funding from a different source, they just want a commercially costed project. So in that scenario, we would provide a proposal for agreed work to be delivered in that way. So this is a very simplified representation of the evidence development pathway, but this is how we like to think about it. So there are several steps that will bring a technology from discovery into adoption. You can see that is the clinical path, but alongside there's also a lot of methodological works that need to be delivered in order to bring let's say, increase the possibility and probability of a successful adoption. So if I start with the analytical validity, so both analytical validity and clinical validity are observational stages of clinical research or just, let's say, research. So in the clinical validity stage, we collaborate closely with the Northeast Innovation Lab. They have a wet lab where they can benchmark your technology with the either with gold standard technology or the best possible reference standard. They have access to biobank samples. They have access to remnant samples through the hospital. Yeah, this collaboration works really well. They have a lot of experiences and can also advise you in the development of the test or refinement of some specific features of the test. So the next stage is the clinical validity or diagnostic accuracy, as we like to call it, so here we want to answer the question, does it work in the healthcare? Again, for this phase, we might employ the innovation lab as well, just because in a scenario where the test would be placed in the lab, then the innovation lab, which is a commercial lab, part of the so the Newcastle upon Tyne hospitals would then still hold your device, so that your device will be in their setting instead of in the general lab for evaluation purposes. So in this stage, samples might be prospectively collected and then again tested and compared with the reference standard, but it will be kind of the real samples, and it will be in the right patient population at the right time in the pathway. So you would not have like that problem of biobank samples when you have no control over when the sample is collected, and you perhaps have only later stage cancers. And then the third step is the clinical utility. So does it benefit the patient? And here we have an interventional study. We can think of it as an RCT, as a randomized control trial, where we also focus on the outcomes. To show that a diagnostic technology brings benefits is a bit trickier. So the usual measures, the usual outcome measures, such as mortality, hospital stay, or morbidity, might not be the best ones to show that the diagnostic is actually bringing benefit, just because they might not show what is the technology bringing to the table. So we might focus on outcomes such as time to therapy or time to treatment. We might focus on outcomes targeted versus broad spectrum antibiotic. So we need to think about outcomes that will really kind of show the value of this new test. So as mentioned, alongside this clinical evidence generation, there is of course a lot of more can be qualitative work, statistical work, health economic work that needs to go into the mix, so that everything is kind of developed in line. So the support that the HRCs can offer is, let's say, qualitative. So in terms of qualitative, we can think about focus groups, interviews, guideline reviews, systematic reviews. So stakeholders analysis, stakeholder engagement, elicitations, pathway analysis, so stuff like that. As a statistical support, we might think about study design, diagnostic accuracy calculations, surveys, survey questionnaires, audits, so auditing hospital data, so analyzing that data. Then health economic input, but also public and patient perspective. So that this is, again, one thing that we can help companies with. We have a in-house panel of public representatives who has by now developed a bit of expertise around giving advice in this diagnostic medtech space. But we are also very well linked with other groups in the hospital, so patient groups in the hospital with maybe lived experience of a particular disease that you are focusing on. Yeah, so just to finish with, there are some things I wanted to talk about in terms of adoption. So the simplest way how we think about adoption is that we have local adoption and we have national adoption. So local adoption will kind of be the bottom-up approach. So you approach a trust, have like develop a relationship with them, even identify a clinical champion that will help you propel your technology. In an ideal scenario, you would develop a really good working relationship with them. You will co-develop your technology with them. So if they tell you, actually, this will work better if that feature would be added, or if it will be developed as a point of care test, then you kind of roll with it, and then you kind of co-develop your technology so that potentially once it's ready to go to the market, they will be your first adopters, and then kind of you can then have this model implemented in other trusts. On the other hand, you have the national adoption, which would kind of require you to go through all the phases, and at the end get the positive, nice recommendation that your technology is clinical and cost effective. Again, the caveat with all the med tech is that there is no mandating it, so that there is the process is not the same as with medicine, when once you prove it's effective, the system can mandate it. So here we just get nice recommendations. So it's recommended. This means that it's included in the NHS purchasing system, but you don't, the hospital does not necessarily need to purchase it. So it's on the system, but there is no mechanism that will kind of imply or suggest to use that particular technology. The only mechanism which is relatively a new one is the medtech funding mandate, which can fast track the technology with strong health economic evidence. So this is something that it's being published, that it's being trialed. And there is another kind of mechanism for startups that it's being trialed. It's the IDAP process. So the IDAP pilot, the innovative device access pathway, which again was there before for the medicines, but they are piloting it now to streamline the adoption of innovative medical devices in the NHS, also for the in the medtech space. So in terms of health economic, the models that you would usually need if you're building your business case for local adoption might be the budget impact model, cost consequence model, cost utility model, but that again, as Gerd did before suggested, will depend on what you're trying to achieve with that. And health innovator partners, which are also part of the supporting infrastructure for developers, can help you with developing a good business case. On the other hand, for the NICE, you need the full economic model, so the cost effectiveness model to demonstrate the clinical and cost effectiveness. So just to finish with, I wanted to kind of spell out a few don'ts. So I see a lot of applications as a whole, so all the work packages and also the kind of the outcome letters. So what the let's say reviewers like and dislikes. So generally, a don't leave it to last minute. So if you need support, so if you need our support or support of any other member of the infrastructure, get in touch far in advance of the deadline. So if your aim is to submit to the next IFRI Product Development Award end of May, don't leave it till the end of May. Don't rush it. So the evidence needs to be generated in steps. So don't try to kind of jump over steps, because that will most probably hunt you later. In terms of stakeholder analysis, don't just stop by only talking with patients, only talking with clinicians, because the ones who really make the decision to kind of fund your, so to buy your device are the managers, the budget holders. You need to understand procurement, speak with commissioning teams. ICBs, if you're looking into primary care, and at the national level, so once you're closer to that, get in touch with, so both with associations such as Association of British Health Tech Industry or British In Vitro Diagnostics Association, but also speak with MHRA, NICE, get yourself self-known to them. Again, in my kind of experience of helping developers going for funding, developing funding applications, there are 2 points of tensions usually. So one is that the developers usually believe that they are further away in the development pathway as we think they are, which we kind of try to smooth in the process. And the second is some of the developers, they try to develop really complex models, while again, from the experience, simple is better, because if you imagine at the beginning you don't have data, so all the data that is available is secondary data, is data from the literature, from past studies, from it can be from expert elicitation, but the uncertainty is really big. So you have not generated the data on your device yet to be able to have the parameters that will inform the model. So start simple and then refine once you have generated the data. Yeah. So that's all from me, and I think we have questions at the end.
So unfortunately today, our next speaker can't join us because she's dislocated her knee, bless her. So she sent in a video. So I'm just going to... this, there.
Good morning. I am Chikom Tefa, a methodologist at the HRC in Diagnostic and Technology Evaluation. I will conclude this morning's talks with an example of the work we have carried out with an SME supporting their development of a new blood test for prostate cancer. So a bit about the background. Prostate cancer is the most common cancer in men. The latest statistics show that there is a prevalence of about 1 in 8. And an incidence of about 55,000 men. So that's new diagnosis each year in the UK. The risk of prostate cancer increases with age, commonly found in men over 50, and with most men being diagnosed between the ages of 70 and 74 years old. So other factors such as ethnicity also increase the risk of prostate cancer. Current diagnosis relies on prostate-specific antigen test, which is a blood test that is used to triage patients within primary care. It has a low specificity, that is, it cannot correctly identify those patients without the disease accurately, which results in patients being falsely identified as potentially having prostate cancer, which leads to overdiagnosis, resulting in unnecessary tissue biopsies and possible infections. So this is because PSA can be raised for other reasons other than cancer, for example, from benign prostate hyperplasia or stimulation of the prostate. So in addition to this diagnosis, also causes anxiety in patients who are referred but do not need to be referred to secondary care. And also, of course, it includes in healthcare costs from unnecessary procedures. I do have to note that there are other examinations conducted, but the raised PSA results is used to refer patients to secondary care. So novel diagnostics that can reduce high false positive rates and those referrals to secondary care are crucial in decreasing or avoiding healthcare costs and also improving patient outcomes. So the SME in question identified some biomarkers that are unique in men with prostate cancer, which led to the development of their test, a blood test, and preliminary lab results of those of the test show that it was likely to be more superior to PSA, with both a higher sensitivity and specificity, having a sensitivity of about 93% compared to PSA's 85%. And a specificity of that's almost double of PSA, so it being 66% compared to 33%. So they needed help in taking this from a technology readiness level 3 to 4, which is basically taking their proof of concept to a validation in a lab. So our solution really was to help them with grant applications and also some further development work, evidence development work. So we supported them and successfully applied for grants, which amounted to about £200,000 in funding, and this were used to optimize or perform statistical analysis of the test, to undertake care pathway analysis, which is alongside some economic modeling, to define the clinical need and potential roles of the test. And funding was also used to further develop the test. So in a review of the guidelines as part of the care pathway analysis, it showed populations, 18 populations that could be considered for the test. And in this considering the test, we factored in the purpose of the test. So whether it could be used for replacing PSA or be used as an addition to PSA, the setting of where the test could be conducted, either in primary care or secondary care or community services for monitoring. Also, the optimal study design to consider in the future, looked at also potential clinical value or the need that's there, the market size, and also how difficult it would be to put the test into market. And this table shows a snapshot of those populations that we considered. So the care pathway interviews were conducted with a total of about 18 clinicians in primary and secondary care. And then these interviews, we filtered down those populations from 18 to 3. And these were where the test could be used as either a screening tool in primary care for the worried well, as a triaging tool in primary care for the symptomatic males age 50 and above, or as a monitoring tool for patients that have confirmed prostate cancer. And consensus from both the primary and secondary care clinicians was that it would be most useful as a triaging test in primary care for more appropriate referrals to secondary care and efficient use of resources. So it was unlikely that the test would be used in screening, as the National Screening Committee would not likely consider this due to the length of time a person can live with prostate cancer before they die. So people with prostate cancer are more likely to die with it than from it. And the monitoring scenario, the PSA was felt to function very well in that population. So an early economic analysis was then conducted based on this feedback and on the populations. And this is our PICO, where our population index test and comparator and outcomes were looked at. So that's, we looked at men aged 50 and above with symptoms of prostate cancer that were being seen, that were visited GP. And the test, index test, was the novel blood test, the comparator was PSA, and our outcomes are costs and qualities. And from the care pathway analysis, we built a decision tree Markov structure, which covered the diagnosis pathway from a visit to the general practitioner in primary care to some biopsy and staging in secondary care, and some long-term outcomes from disease management. We had these 6 states really, where symptomatic patients, where all the procedures related to diagnosis, where patients were seen in the symptomatic state, and then they were either discharged or disease-free. That's and left the pathway in disease-free stage. Patients with prostate cancer were being monitored within the active surveillance stage, and could actually be either diagnosed with a metastasized prostate cancer, which would lead to death, and all patients could die from all causes. And our scenario is also of where we're using the novel test as a replacement for PSA in the primary care pathway, but it could also be used in conjunction with PSA. So this model was more populated by parameters obtained from various sources. For the test diagnostic accuracy, the statistical analysis was conducted by the HRC from the remnant samples, and a literature review was also conducted for the performance of other tests such as biopsy. We used the literature and expert elicitation to obtain some input values for resource use and prevalence. For costs, we used the NHS reference cost at the time, which is now called the National Cost Collection Index, and also some values for staffing costs from the PSSRU. For utilities, that is the values that represent the state of health, individual state of health, that range between 0 and 1. We obtained this from the literature review, so these values were for our patient outcomes. For our model analysis, we ran a micro simulation of about 100,000 men This generated incremental cost effectiveness ratios, which were expressed as cost per QALYs for the proposed strategies. So that's the new test and PSA. And to recap, the ISA is calculated as the difference in cost between the two tests divided by the difference in QALYs. And the most cost-effective strategy achieved the most health outcomes per £1 spent over the person's lifetime. The NICE threshold of 30,000 denotes this utmost cost that society would be willing to spend to gain one QALY. And this was used to assess whether the test as a replacement for PSA was cost effective. And our other measures, the time horizon was the population's predicted lifetime based on the National Office of National Statistics life tables. We used 1-year cycles to accrue our costs and QALYs, and also used the UK NHS perspective to obtain our costs and QALYs and at a discount rate of 3.5% as per NICE reference case. This was all conducted using the Triage Healthcare Pro software. And to determine whether our model was robust to changes, we used a deterministic one-way sensitivity analysis and also threshold analysis to determine the optimal cost of the test. So when we ran the model, we found that the test was cost effective. It was basically cheaper than the PSA pathway, current pathway, because less people were being referred for biopsies, and there were better patient outcomes stemming from people being appropriately managed. So there was like less anxiety associated with unnecessary referrals to secondary care, and more people were actually being referred to when they needed to be referred. So costs, as you can see, they were higher for the current care pathway, the PSA pathway, at about £5,500 per year, and QALYs were like £33,000, 33.53, excuse me, QALYs. The new test pathway accumulated costs of about £4,800, and accumulated QALYs about 33.68 per year, which shows that actually it was dominant because on the cost effectiveness plane, as both it was both cheaper and more effective. So our one-way sensitivity analysis displayed here in a tornado diagram, where we changed each parameter at a time to show how the results differed or changed with any change in parameter. Our model showed that actually it was quite robust to these changes, where the prevalence and the cost of the test and specificity of PSA and the novel test were actually cost effectiveness drivers. They impacted the results, but they did not affect the overall cost effectiveness. As you can see, the willingness to pay threshold at £30,000 per QALY was all the optimum costs were not greater than these £10,000 per QALY. Okay, and in our outcomes, what we added to the evidence that was needed by the company, we identified target population for future research, where that's the patients within primary care visiting their GP with symptoms of prostate cancer. And this population, we noted that the sensitivity and especially the specificity needed to be optimized for this population. However, there were some gaps also identified in the knowledge that we have, so that could be explored in further clinical study. Firstly, this model was based on preliminary lab data using remnant samples, and this data was derived from patients who are at a later stage in the prostate cancer pathway. So basically, these results cannot be generalized across to using in primary care. So a study looking at patients within primary care prospectively collected may be more useful. As one of our recommendations. Secondly, some of the parameters that in the model were subject to uncertainty because we obtained these from expert elicitation. And again, this limitation can also be addressed in a follow-up clinical study where samples are collected prospectively from suspected prostate cancer patients in primary care. Okay, and then these could also be used to further build the health economic model. So this developmental work highlighted how the company could best develop their test to meet a clinical need and also produce cost savings potentially. And the company, as you can see, found it very valuable to work with us. And the company are currently working on commercializing their test to meet those SAIT targets. And these are my references. And I hope you found this talk useful in showing how the HRC-DT can help you in gathering the evidence you need to for further funding and development. My email is provided in the slide. That's chico.mutefa@newcastle.ac.uk, as the general HRC email box is also included. Thank you all for listening.
Thank you to Chico. So we're just going to move into the expert panel and kind of fireside chat now. So if anyone's got any questions, then open to the panel. And that's also online. If anyone in the audience wants to ask a question and feels comfortable saying who they are and what their company is, just so we can contextualize it, feel free. But if it's commercially sensitive, maybe you're a startup early stage and you don't want to say what your company is, then that's fine, but the option is there. Has anyone in the audience got any questions for the team? Great. Jen, have you got the mic? There's sorry. In the front. Sorry.
Thank you very much to Dawn.
It should start in a minute.
So, I don't think we need the mic, do we? Thank you very much for both the all three talks. My name is James. I'm Manager Director of Brainfood Limited that was started in Newcastle 10 years ago. We have a nutraceutical intervention for brain health, which we're running a clinical trial with the University of Edinburgh. It's an MRC grant application that we're going through. I just had a couple of questions on health economics, if that's okay with you. In terms of, I call it benchmarking, but effectively we'll talk about opportunity costs. Where we are, is it possible to get the economic health arguments for the pre-existing interventions that are already on the market?
So in terms of,
so let's say that we're going, we think that we have an intervention that rivals a pharmaceutical application, which has obviously gone through nice applications in MHRA, and we've run some of our own preliminary numbers. We're trying to ascertain how we compare to these existing interventions. I don't suppose any of that data is readily available.
Well, some of it will be. So some of it, so you may be able to look at the technology appraisals as published by NICE. You know, but some of the information will be redacted, but a lot of it isn't. So some of that you will be able to get, and you'll also be able to look at, you know, just traditionally published academic papers, which, you know, aren't redacted on those specific technologies. So a lot of that information you will be able to get.
Okay, super. Just a couple more for me then. The 3.5% discount rate, which was on the presentation, is that kind of just the mandatory NHS expectation? Should be building that into our commercials?
So the idea behind that 3.5% discount rate is that in economics, there's an idea whereby, I mean, it's a bird in the hand is worth two in the bush or tree. That is the concept. So we, as a society, as individuals, we value things in the present much more strongly than we do in the future. So if I was to say to you, I'm going to give you £1,000 and I either want you to pay it back to me tomorrow or in 5 years' time, which are you going to choose? 5 years time, yeah. But if I say to you, okay, I'm going to give you £1,000 tomorrow, or I'm going to give you £1,000 in 5 years time, what are you going to choose? Tomorrow, yeah. So it's this different preference in terms of when we receive benefit and when we incur cost. And so the idea behind that discount rate is to try and allow for this benefits and costs that occur in the future to, be valued less than those that are incurred up front. And this has pros and cons, but that 3.5% discount rate is purely to do with that. It's not to do with that your technology has to be 3.5% cheaper. It's not that. It's just the concept of valuing things differently over time and how we try and account for that preference within an evaluation. Does that make sense?
Yes.
Okay.
So the US reimbursement model is obviously fundamentally different to sort of the presentation. I was just wondering if you had any insight and how perhaps you could talk through the economic argument for financial viability and acceptance that might be expected in the US by insurers as opposed to.
Yeah, so I mean the concept is the same. So we want to be doing things that are value for money, however we define value for money, whatever specific threshold we use. So obviously the US has a different threshold, but their healthcare system is fundamentally different to the way that we reimburse our healthcare system. So you can, I mean, whilst I don't do any work that is focused in the US, my work is primarily UK based. What you need to do is make sure that if you're interested in that market, you work with individuals who have a better understanding of that market. But fundamentally, it's about thinking about what the pathway looks like there, what the costs, what the resources are that are being consumed there. But the principle is the same. We do economic evaluation the same here as we do over there. It's just what we put in and what we get out is slightly different. But conceptually, it's the same. So it's just making sure that you understand what those thresholds are. So if it's $50,000, a quality, or if it's $100,000 a quality, whatever it is, you understand what that is, and you develop your pathway, because that may be different to the UK pathway, and then you work out what the costs and outcomes are relative to that. That makes sense.
Final one for time, and you may or may not be able to give any insights to that bit, how you kind of work on the business side as opposed to on part of the trial. But for us, there's two healthy economic arguments. There's obviously one which is the really detailed one, which is fundamentally based on who pays for it, so the NHS, the patient, the insurance company. And then for us, the second one is the healthy economic argument for life science VC investors, which is a stripped out or simplistic version I would expect. Do you have any insight as to perhaps the healthy economic argument that they would be happy with viewing as a first pass for, dare I say, it passes the sniff test, here's it in an investment deck, and in DD is a little bit more detailed, but it's not going to require the same sort of level, especially when it's very early stage. So I mean, we're doing a POC at the moment, and therefore, we don't really need to make the healthy economic argument at this stage. We need to start.
Yeah, so I might see, Jana, do you have any insight with regards to that aspect of, the investors, through your experience with the HRC? I mean, if you don't, that's fine.
You mean how to make an argument to persuade investors? Because investors, they usually they want to see the bigger picture, right?
Well,
Are you talking about VCs?
Yeah, absolutely. So
Okay.
Yeah, maybe Dawn, maybe you can.
I think it would depend on the VC, how much detail that you're going to put into it. And I would put it in as a matter of course. But some of them are just going to be looking at your cost benefit and ROI anyway. They're not necessarily going to be going into that much detail with the health economics.
Yeah, so I think it kind of depends, doesn't it? So for some, you're going to be selling the dream. So you're selling the idea, the concept, and the details don't matter as much, but for some people it'll be all about the details and are they going to make their money back? So it's a sort of a balancing act, isn't it, between the two? So if conceptually, you know, you're going out to change the world, that's the dream vision that you're selling, and if you're going to make a bit of money on the way, that's great. But it's trying to make sure that you've got your bigger picture aligned, but also you've thought through the processes. So is it ever likely, you know, one of the two fundamental things, does it work, right? Is it, you know, is it helpful? How much harm does it create? You know, as long as you can get that balance correct, you know, it's probably going to be a good thing. And then, can we afford it? And, you know, if you're going to fall down on either of those, then people aren't going to invest. But if you can show the first and guesstimate the second, so say it's likely to, you know, you don't know for a fact, but it's likely to be cost effective, value for money, you know, and you're going to demonstrate that as you go along, then it may be worth investing in, as long as that first principle holds.
And I think as long as you have like a kind of clear strategy of like what are your next steps and how you're kind of moving toward adoption, that's the kind of bigger picture that they are looking for. So when I was talking about kind of going to approaching the adoption through these different streams, so either, I mean, both going through local adoption route, but also kind of working toward the national adoption route. I think this is the strategy they're looking to, and kind of they just kind of want to see that that you have paved your way toward adoption. I mean, it probably will depend whether they are UK based or US based or kind of foreign. But yeah, I think speaking with other companies that got this investors money, that was the main thing that they were looking at. So having like a clear strategy of next steps, so understanding the system and working your way through. I just wanted to ask, because you mentioned brain, have you been in contact with the Cambridge HRC? So just to let you know, there is a Cambridge HRC who specialized in, so they specialize in brain injury, but they are kind of working in that field. But also we just employed a health economist from US, so she might be able to give you a bit more of perspective around that market as well.
I think maybe as well, are you working with the Department for International Trade, Business and Trade? Yeah, because they would have more of a idea in terms of investors, kind of stats, data, the depth that they're looking for as well. So I would speak to the health specialist at DBT. Any more questions from the audience?
This is a question for Jana. Thanks for your presentation. All this pathway you mentioned about going from concept to, if a company, because I deal with companies all around the world, and we talk, and I talk very highly of the NIHR, even though I think they're a little bit esoteric. Would it be open to having collaborations with companies who want to use these great resources, the biobanks, the knowledge, but without necessarily the last step of NHS adoption? Is there a condition that it has to end up with the NHS?
No.
Okay.
No, that's not a condition. Maybe, yeah, maybe that's a good point. So we can just kind of scrap the NHS there. We also help companies that want to go to UK market, European market, Asian market. So no, it does not need to end with with the NHS. I think the like resource we have at hand, just because we are working part of the locally part of the hospital, but also like we are well connected with other hospitals in England. So that's where the data is generated if you're approaching us and if you want kind of this type of access. But in the past, we also kind of collaborated with generated data in US, generated in a partnership, generated data from Europe. So no, it's not limited for the NHS. It's very broad. It's very broad. There are also technologies that are purely targeting the like private market, health, wellness, healthcare and wellness. So their endpoint is not the NHS.
Okay, thank you. Yeah, because I imagine the data you are generating, whether it's scientific, whether it's health economics, whether it's whatever, stands whether you're presenting it to a NHS trust in Sunderland or the equivalent in Milan or the United States. That's the same.
Yeah.
Thank you.
Yeah, some of that evidence is generic, but some of it can be quite specific. So if the care pathway is fundamentally different in Milan versus Sunderland, and if people interact with that pathway differently, then there will be different costs and benefits that occur.
Yeah.
And so you may not be capturing both appropriately in the two if you try and generalize from one to the other.
You're right. You're right.
So yeah, so there are nuances, but
yeah. So just one follow-up question. This may be a silly question, but can you do it up to a certain point where it's actually a term, but pathway agnostic? So the evidence is there, and then the last bit can be adapted to wherever you want to adopt it. Does that make sense?
Yeah, so I think if we're thinking about, if we disentangle the two, the costs and the effectiveness. So the effectiveness is probably more generalizable than it is appreciated or traditionally is used. So I know that in the UK, when we think about effectiveness, ideally NICE want to make decisions on effectiveness evidence that has been developed on the UK population, as opposed to like population in China or India or Australia or mainland Europe, or the US. They prefer evidence that has been generated on our population, because then that makes decision making more comfortable. It's more generalizable to the UK because it's UK population data. But some of that data probably won't differ that much if it were French people, or if it was American people. If we're thinking about biomarkers and levels going up and down, I mean, we're all people, and a lot of it will be the same. I appreciate that. There will be differences that relate to specific populations, so it's not uniformly generic, but a lot of it will be the same. So yeah, but costs can be really different, and who incurs those costs can be very different. So in the US and in other parts of the world, there is a lot more out-of-pocket expense, which is a lot smaller in the UK. So yeah, so it's about where those costs fall. Yeah.
Another way how we started doing it is because, like, when you implement your new technology into like an existing pathway, you might want kind of almost zero disruption, so just maybe replace the test. But usually, if there is something really kind of game changing, it will disrupt the pathway. So instead of looking what is already out there, so what are the guidelines, what are the national guidelines, local guidelines, what they are actually doing, and what the variability within the system, you approach it from a different perspective. So you in terms of the research that we do is, for example, through the Delphi exercise, we work out in terms of priorities, how will the system needs to be kind of set up in order to be an optimal place for this technology to be kind of so to be implemented in this system and to work optimally for the patient benefit, but also cost-wise and so on. So we basically generate the best case scenario where the technology would fit, and in this sense, then you would also change the pathway. So you would kind of adopt the technology, put the technology to adoption, to use, but also change the pathway. And that's usually the best scenario, because in UK, so if you change the pathway and the pathway is then endorsed by NICE, then your technology will be mandated, which is not the case with the recommendation.
Thank you. That's all we've got time for today. We've got to move into the one-to-one sessions now. So thank you all for attending. Lovely to see you all. And if you've got any questions that we haven't answered, you can just drop us an email and we'll get back to you. Okay, thank you.